All right, guys, today we're going to talk about burn care. We don't talk about burns much, which we probably should. Being a fire-based EMS system that we are, burns, our ability to treat burns is very important. We have the potential to encounter them more than other services would due to the nature of our job. So burn care first, you start with anatomy. We're going to cover anatomy and then talk about assessments, how to treat them. And then we're going to get into some changes that have came out, some easier ways to do things, and hopefully make it a lot easier on you guys. So first, anatomy. Start with your skin, right? We know we have three layers of, technically four layers. First skin layer is your epidermis. Your top layer is very thin. Most of your body, except for your like bottom of your feet, on your hands where you have calluses, is thicker, but your epidermis is pretty thin, not really that tough, and it's on top. The next layer down is your dermis. That's the majority of your skin, the biggest part. It's about 10 times as thick as your dermis on the outside. After that, we have subcutaneous level, where we have vessels and fat, and then below that you have your muscles. Okay, so 4 different layers that's in there that could be involved in the burn. The main ones we're going to deal with are the top 3 most of the time. But when you talk about classifying burns, it all has to do with those levels of which ones it affected. So the first level, we used to call these first, second, third, and fourth degree. You can still use that. Some people do. They're also allowing now, they're teaching that you can call it a superficial burn, partial thickness burn, full thickness burn, or full thickness with muscle or deep tissue involvement. Some people that's easier. I don't think it's any easier, but it's completely up to you. Whatever terminology you use, they're going to know what you're talking about, and they're going to understand it. If they ask you for one, you tell them, and they want the other one, you have to come up with the other one. But so superficial or first degree burn, that involves your first layer, that dermis. That's a sunburn or a thermal burn, like a minor thermal burn, like a steam burn from a dishwasher or something like that. That's going to be most of those. Most of these don't require emergency care. They'll be healed within a few days, and they are just painful. Okay, second degree burn or a partial thickness burn is when it gets into your dermis. It's going to be a lot more painful down in your dermis where the nerves are at. You're going to really get into there. The main thing to tell you that's a second degree burn is blistering. If you have lots of blistering, big, especially large blisters, that's a second degree burn. Third degree or full thickness burn is going to be all the way through your first 2 layers and down to that subcutaneous tissue. Third degree burn, going to look very leathery the way that subcutaneous tissue burns, and going to be pretty serious. They say that third degree kills all the nerves, so there's not pain in the third degree, but remember the third degree is surrounded by first and second degree burns, so it's going to be pretty painful. The last is your fourth. The fourth degree burn or a deep tissue involvement burn. This is when it's all the way down to your muscles and bones. You're going to be able to see their bones, the charring. This is going to be there's going to be a lot of charring and black. Their skin's essentially going to be completely gone. Muscles are going to be mostly gone. So these are going to be really serious, obviously. Assessment. So we kind of know the idea of what a burn is and how it happens or whatever. Next, the assessment. How do we figure out what do we do when we first get there? What's most important? Very easy to get tunnel vision to the burn. It's going to be very painful and very easy to get sucked into that. Don't forget you need to do your ABCs. Particularly in burns, ABCs are very important, especially the A. If we have any involvement of the airway in that burn, then you could have a lot of problems very quickly. Their airway can swell shut and close off. So looking for soot around the mouth, looking for ashes around the mouth, looking for swelling in the tongue, burns of the mouth, obviously burns of the face. If they're having a lot of trouble breathing or making an excessive amount of mucus and sputum and they're blowing air bubbles trying to breathe, that person's going to need an ET tube to secure their airway. B is obviously breathing. We always want to look at their lung sounds. There's a lot of superheated gases that could have been around them when this burn happened, depending on if they sucked that into their airway. So we could have a problem with the breathing. Listen to their lung sounds really well. Also look for, when you're assessing their breathing, is it rapid, is it labored, etc. Do they have a lot of wheezing in their lungs? And then next, while you're watching their chest, do they have circumferential burns of their chest? So if you have a burn that goes all the way around your chest, as that thing starts to tighten up like burnt things do, it's going to make it harder for you to breathe. Last to see is pulse, obviously. We don't want to be treating a burn the person doesn't have a pulse. So ABCs, and get through them. And then next we want to expose them head to toe. So get all their clothes off, figure out where they're burned at and what's causing the burn. One of the best things we do right away is strip them down, get their clothes off of them if there was something on those that's not on them anymore. We start checking for burns head to toe, and we're looking. Initially, we can kind of assess and treat at the same time. So as we're looking head to toe, we want to stop anything that's burning. So if there's still chemicals on there, still liquid on there, obviously if there's a heat source, we're going to remove it, but we're going to get that stuff off. So chemical burn, they say brush it off. Be very careful doing that, not to blow it into the air. Really the answer for us is any burn, thermal burn that's still hot, chemical burn, any type of liquid burn, liquid or dry chemical, we can wash those off with water. Water's our friend almost always. We want to use a lot of water. Obviously, if you have an MSDS available, grab the MSDS sheet on the chemical if it's at a factory or something, or a place of business and they have one, and read the MSDS and look, and it'll have treatment information in case you get it on. Never put ice or really cold water on burns. It does relieve some pain initially, but it causes more problems later, hypothermia and healing. So what do we put on them? We use burn gel. Okay, so in our ambulance, in the trauma section, right above you, it's going to be trauma 6, I believe. Yep, trauma 6. Okay, and you're going to have these water gel bandages. Okay, these are particularly made for burns. We used to use, you probably were taught this too, depending on when you're at school, but you take sterile dressing and damp, water it down and put it on there so it doesn't stick. But these are made specifically for that. They're much better. They have a cooling sensation too that makes the burn, helps with the pain of the burn. Okay, so we want to use these and not damp bandages if possible. We have a lot of these. There's different sizes. This particular one's a 4x4. There's 5 in your bin. They have a lot of sizes of these, up to real big ones. Bigger burns than that, we have a burn sheet. Okay, this little sheet here. You put it draped or laid on the cot, so burnt skin doesn't come in contact with this. It's pretty close to the same material as that anyway. But it's just basically a sterile sheet, and that prevents contamination from getting into the burn. So if you estimate it's a lot of burns and we need to wrap them up, we can use our burn sheet. Okay. Next, most important is hypothermia precautions. You're probably told fluids, and we give lots of fluids as fast as possible. Okay, we're still going to give fluids, but we're not going to that's not our most important thing that we're doing. Okay, so once we get the burns, we find them, we assess them, we start treating them with burn gel. Okay, next is hypothermia. This person's skin, which regulates their temperature, is exposed now or gone or damaged. So we want to, if it feels comfortable in the ambulance for you, like if it's 65 degrees and here 70 degrees, it's way too cold for the patient. So we're going to need to cover that patient up or turn our air off, and keep that air or the temperature, their temperature, from getting lower. And I said that first because it goes right into fluids. Okay, we were all taught Parkland formula as ways to come up with how much fluids we give, and that's based off of body surface area. Okay, so what we know is that we don't need to even do a Parkland formula estimate. That's a 24-hour formula. We don't need to know that. Okay, the thing to look for first, as far as fluid goes, easy step, give 500 milliliters of normal saline to a patient that's been burned on the way to the hospital. That's about how long it takes anyway, through one IV. And then the hospital will pick it up from there. If you have a problem with hypotension or profound dehydration from the burn, obviously, and you're seeing clinical signs of this, treat the hypotension with fluid. But don't worry about doing Parkland burn formula. Don't worry about any of that. Don't worry about giving them as much fluids as possible. Just give them 500 on the way to the hospital and let the hospital take over from there. On the body surface area, so you guys have probably all seen this, right? Remember Parkland formula, rule of 9s, okay? Finally, after 10 or 12 years of me complaining about the rule of 9s, they changed it to the rule of 10s. So I used to always say, Doesn't make sense that they're 9 because it makes the math hard. Why don't you just make it 10? It's already an estimation, so it doesn't need to be perfect. So if you make all the 9s a 10 and make the 18s a 20, the math is much easier. So if you call in and you tell Hillcrest I have 36% total body surface area burned, they're going to say, Roger, 40%. They're going to round up anyway. So I'm not sure why they ever did it this way. I assume it's for accuracy of the formula for fluids in the hospital. The hospital's not using this anymore either. But if it's an arm, it's 10%. If it's the front of the chest, 20, back is 20, head is 10, leg is 20, leg is 20. Okay, so easy math, easy to do. Okay, so rule of 10s, remember that. Rule of 10 is not the rule of 9. Oh, we lost our light. Rule of 10 is not the rule of 9s. Okay, make it a lot easier. So recap, right? We got 4 different layers that could be involved in a burn: 2 skin, 1 subcutaneous, 1 muscle and bone, the last muscle and bone. What do we classify burns as? First, second, third, or fourth degree, or superficial, partial thickness, full thickness of muscle tissue involvement. Okay, we assess people head to toe. We always check the ABCs first on every single call, no matter what. It's a trauma. Burns are trauma, so trauma naked, check for burns, head to toe, systematic, find it. When we do find it, we can classify it real quick because we now have the rule of 10s. 10, 10, 20, 20, 20, 20, 10. Right? Rule of 10, super easy. Come up with your formula. You know how much is burned. You know what kind of burn it is. Treatment wise, don't use damp paper towels anymore, damp sterile dressings. Use the cold burn gels. That's why we buy them. Buy those. We got big burn sheets. Okay. Pay special attention to hypothermia procedures. 500 fluid for people that got burned. And don't be afraid to intubate somebody if they have any kind of airway involvement. That's burns in a recap real quick. Thanks for watching, guys. Hope you got something out of this. If you have any questions, let me know, and I'll get back to you with an answer. Thanks for watching.